Hello and welcome to GP Bootcamp. Today we're going to be talking about vertigo. It's one of those difficult and sometimes annoying symptoms that patients often present with, saying that they've got vertigo when actually they're probably describing symptoms of dizziness or giddiness or feeling faint. Or they come in with the latter symptoms, and when you kind of pin the history down, it sounds very much like actually true vertigo. So you've got to be able to differentiate the two first of all, because the treatments dictate will be completely different. So what is the standard definition of vertigo in the textbooks? Well, they say it's a false hallucinatory perception of the patient within his environment, or the environment moving around the patient. Now, what are the causes of vertigo? Well, we group them into two main groups: the central causes and the peripheral causes. If you think about the central causes, they involve the actual brainstem itself, or the cerebellum, and the common central causes will be vascular causes like strokes, demyelination, or space-occupying lesions. So the history is really important to dictate whether it's a central cause or not. And also doing a full cranial nerve and upper and lower limb neurological examination will be really, really important in order to confirm your findings. Peripheral causes, well, these are problems of the inner ear, and the common causes of the inner ear would be, as I mentioned, the inner ear, the vestibular system, and also the 8th cranial nerve. Commonly, this would include things like benign positional vertigo, Meniere's, and acute labyrinthitis. So how do you differentiate between which one of those three it is in the history? Well, there are two really, really important questions to ask. Firstly, the timing. When do these attacks of vertigo occur? Do they occur in a matter of seconds or minutes, in a matter of hours, or in a matter of days? If they occur in a matter of seconds to up to a minute, then it's likely to represent benign positional vertigo. The chap that comes to you in surgery and says, "Oh, I'm at night, I turn my head suddenly and I get this sudden episode of vertigo lasting several seconds, but then it corrects itself." It sounds very much like benign positional vertigo. If it lasts longer than this, up to kind of a couple of hours or so, then you can think of Meniere's or acute labyrinthitis, but with acute labyrinthitis it can last even longer, up to a couple of days. Now, the second important question to ask, other than timing, is are there any other associated symptoms? Now, these associated symptoms would include things like nausea and vomiting, as well as tinnitus and deafness. Now, it's the presence or absence of these symptoms which will dictate whether or not you're looking at one of the three causes that we've mentioned. So if you're taking benign positional vertigo, for example, you're going to have you're not going to have any nausea or vomiting. You're not going to have any tinnitus or deafness associated with it. If you take Meniere's, you'll have all of them. Not only will you have the vertigo, but you'll have severe bouts of tinnitus, deafness, as well as nausea and vomiting. Whereas if you take acute labyrinthitis, then patients will present with the symptoms of vertigo. They'll present with nausea, vomiting, but generally not deafness. So these two questions are really critical in trying to find the likely subgroup causes of the peripheral causes that we've talked about. Other ways, and perhaps for more intelligent people than myself, to try and differentiate between central and peripheral causes is nystagmus. And they say that peripheral causes of vertigo tends to be kind of easily fatigable and away from the side of the lesion, or where the affected ear is, whereas central tends to be towards. But I don't want to get too bogged down to that, because it can be sometimes quite difficult to interpret nystagmus. So the key thing is the history, and asking yourself, as I mentioned, whether it's central or peripheral. And then when you think it's peripheral, looking at the timing and looking at the presence or absence of those symptoms that we've mentioned. I'd really like to hear your opinion with this and how you try and sieve out these symptoms. Many thanks.